Okay, I think, yes, I think Stephanie, if we can start with introductions. So my name is Jill Stiegel. Many of you know me already. I'm a nurse practitioner in palliative care at the VA. Specifically, I work in outpatient. So I do clinic and telepalliative with Stephanie, working with veterans in palliative care.
And my name is Stephanie Hartz. I'm a social worker here at the VA for 13 years. I have 2 roles, serving as geriatric telehealth social worker and palliative care telehealth social worker. Both these programs have an emphasis with rural and highly rural veterans. So that's what we're here to talk about today. My goal is that it's not like drinking out of a fire hydrant, but it's a talking points for VA benefits and services, so that if veterans have questions, they know to contact their PAC social worker and have a bird's eye view of questions and resources to ask about.
Thank you so much, Jill and Stephanie, for being here today. We really appreciate it.
Yes, of course. Thank you. And I wonder if Laura Madeline, just for the sake of it being VA, if you can introduce yourself as well.
Yes. Okay. I'm Laura Madeline Tebow, and I am in the outpatient palliative care social work role.
And then we'll just kind of jump right in. So Stephanie and I have a clinic which meets once a week on Wednesday mornings that is specifically for palliative care referrals that come in for veterans who are rural. And that's what we're going to kind of start with today. Why isn't my screen moving? There we go. So just a few facts from the Office of Rural Health, and this is the Office of Rural Health through the VA. So as our veterans are getting older, they are also residing in more and more rural communities. So 4.7 million rural and highly rural, and we'll kind of talk a little bit about that. Veterans with 2.7 million enrolled at the VA. And of course, our population is getting older and older. 55% of that 2.7 million are over the age of 65. And even though palliative care works with veterans of any age, the majority of our consults, the majority of the patients we serve are in that older age category. So our program, we do consults and co-management of veterans with serious illnesses. So we only get involved when another provider, be it a social worker, a nurse, a doctor, a nurse practitioner, a specialist from outside, asks us to get involved. So we are the ones who decide what their rurality is in terms of where they live and how we can best serve them based on their address and their geography. So first of all, we meet with them. We have a full consult up to an hour where we kind of learn about the veteran, learn about their supports, and we talk about the disease that they have and how their illness affects them. And then we can talk about co-management, whether that's with a specialist like an oncologist, primary care, a specialist from the outside, since a lot of these veterans who are rural aren't maybe coming to the VA for the majority of their primary care. And we talk big picture, right? What's the goal of the veteran? What's the goal of the different care models that are being offered? We talk about the future, specifically what's their preferences for treatment related to their disease, whether it's dementia or COPD or cancer. And we can talk a lot about symptoms. So we talk specifically about symptoms related to the disease. So we don't do things like chronic pain management, but we do cancer pain management. We talk about anxiety related to shortness of breath, but we don't necessarily talk about depression and mental health as a big picture. We're not specialists in that. And we can talk a lot, which is what Stephanie does, about community-based resources, VA benefits, and we talk a lot, of course, about hospice, both providing education on hospice, talking about VA hospice benefits, and then making a recommendation or a referral if needed. This last point I think is pretty important for our team, and that's how I wanted Laura Madeline. So Stephanie and I deal with rural veterans, and in the other clinics I serve where we're dealing with people who live in Denver or live in Aurora, Laura Madeline is the social worker for palliative care. But we try to make sure that when the social worker's involved, that we're working in an interdisciplinary team approach. So we meet with them together, we have conversations together, and then we decide kind of moving forward whether or not the social worker follows up or I follow up, or maybe, getting a psychologist involved or a chaplain involved, something like that. So this is sort of what I was speaking to before. So, right, there's no age requirement. All of our veterans are adults, so there's no such thing as children here. We talk about the ability to be diagnosed with a chronic or serious illness. And I always say that seriousness is a big piece of it, because something like diabetes is chronic, but we want to talk to people more who are having problems managing their disease as opposed to early on in a disease management. So we talk about end stage disease, maybe terminal disease when we know that this is going to be life limiting, where they have a year or two where we think the disease will naturally progress. And it really doesn't matter. We see a lot of veterans with ALS because we're a hub here in Denver. A lot of people with cancer, dementia, and then heart and lung disease, liver disease, renal disease. And a lot of it is just kind of getting to know the veteran and talking with them and what makes their situation unique, who supports them, how the disease affects them. And the symptoms are not, we talk about classic symptoms, right? Like dyspnea related to COPD. But sometimes the symptoms that people have that are interfering with their quality of life are not sort of those classic symptoms. And what we try to really talk to these rural veterans about is we have a very wonderful interdisciplinary team where we have a pharmacist that joins us. So our pharmacist will call them ahead of our scheduled visit to review their medication. So we are going into the visit with a good idea of what they're taking, who's managing it, where they're getting their medications from, if it's the VA versus a local pharmacy. And then we talk about what I'm going to have Stephanie go into this a little bit more, but really the 4 M's that are there, which is mobility, what matters most are their goals of care, how they're managing or coping with the disease or the progression, and their medical decision making, right? Are we talking to somebody who can make their own decisions and tell us what they need, or do we need to get more people involved? Stephanie, do you mind talking a little more about age friendly?
Yes, this is a highlight for our team here. We're age friendly level 2 recognized. I think we're coming up on 2 years now here for our Tele Palliative Rural program. And then also I work in Tele Geriatrics, which I'll talk about a little bit after this. But Jill alluded to, we ask what matters to the veteran, what's important, and then how can we help them support their goals through the lens of what matters in quality of life. The pharmacist talks about medications as well as Jill, mentation, mood, are they depressed, is what can be addressed there, do they have dementia, and then mobility. Folks, if you're familiar with age friendly through the Institute for Healthcare Improvement, this is just something that our clinic asks all of our veterans who are 65 years and older. And then
go ahead.
Yeah, I'm gonna go for this. And so after the appointment, so we do visits by video. Either the veteran has a tablet at their home or they drive to their local VA community-based outpatient clinic so that we do video visits to them. We often ask that they have a collateral person. One, it's helpful to verify the information that's being provided, and two, have another person hear the information and be present for that discussion. So after our 1 hour new consults, we address function. Are there ways to improve mobility when it comes to a walker, a wheelchair, a transport wheelchair that the VA can order for DME equipment? Caregiver support is big at the VA. I'm going to talk more about that a little bit. What are recommendations when it comes to medical care? The VA has many resources, and we know in the rural areas, there's not a lot of resources, period. So besides just wearing the VA hat, I, as a social worker, also focus on what's available in the community. Should the veteran be thinking like a civilian and maybe an older adult in a community, what services are available that route? We have a nutrition department. We love to send Ensure to folks. The first step is they need to meet with a dietitian from the VA for ordering that. We definitely lots of advanced care planning, completion of the MOST form, life-sustaining treatment initiative here at the VA. We are big on that as well in palliative care. Jill does a lot of collaboration, gathering records, connecting with those community specialty providers, which is really important when we think about veterans that maybe live in La Junta, but they go to Pueblo for their care. Sometimes, many times, the VA does not get those records. And so Jill, in my opinion, serves an amazing role in helping connect community care specialty services to the VA, and acknowledge what we have going on, and how can we collaborate together instead of our own separate healthcare systems. And then we have the VA concurrent care option. Jill, do you want to talk a little bit about that?
Yes. So we have it's called a concurrent care, but it's really concurrent care for hospice care. And it's a unique option for veterans compared to when Medicare pays for everything. Like for an older adult, if Medicare is paying for hospice, the best way I try to explain this is people sometimes have to pick and choose, right? They have to maybe pick and choose the medications they're taking, because if Medicare is paying for hospice, Medicare will pay for the medications for comfort, but maybe they won't pay for that blood thinner. And there's this sort of option of, well, if you have hospice, you can't have this. So with concurrent care, the VA sort of agrees to say, as long as someone's eligible for hospice, and that eligibility piece does not change. So people still have to have a comfort focused treatment plan, and they have to have a life expected prognosis of 6 months or less. So those two things can't change, but maybe they have severe cancer pain, and by treating the pain with palliative radiation, the pain will be improved. It doesn't affect the cancer, but it affects the pain. So it's palliative care that will still be covered by the VA regardless of who's paying for hospice. And that's how I always want to say that. So Medicare can pay for hospice, but maybe the VA will pay for palliative radiation. Maybe the VA will pay for that blood thinner. Sometimes insulins will come up, right? So the VA will still be able to be a payer source for some things, and maybe they pay for everything. They're paying for the hospice agency, they're paying for the nursing home stay, they pay for the palliative radiation. And us as the providers get to pick and choose when something is concurrent. Sometimes we have to sort of go up the chain, but it's sort of this idea that the VA is going to pay for a few more things to make sure that our veteran is comfortable and to make sure that they have appropriate care at the end of life without having to say, in order to have this, I have to give up this. And the next one, the hospice referrals. So we can obviously make hospice referrals. And just for a brief understanding, the VA does not have a hospice. That is a common misconception for many people. Will say, well, I want the one the VA has, but we pay for community hospices, as you all know, often based by geography, right? Sometimes there's a lot of hospice agencies available, like in Denver, and sometimes there's one. So the VA will contract with local agencies to provide hospice, and we pay at the exact same amount per day diem that Medicare does.
And then home-based primary care, I put that under recommendations because sometimes we know that our older, frail veterans sometimes need that VA hug and a higher level of care and support at home. And so instead of veterans coming to the VA for their primary care, a whole interdisciplinary team of staff go to the veterans home for HBPC. And I included that on a later slide, so I'll just tease it for now until I can share a little more.
And along those lines, Stephanie, I don't know if you're going to bring it up, but hospice and home-based primary care can coexist. And that's pretty important because families are often very worried that, again, that they'd have to give something up.
Yes. So I've started in a meaningful way to try and break down different VA resources. when it comes to palliative care or our older veterans, folks on this call may be familiar with Dr. Elizabeth Holman. She is our psychologist. She can provide in-person palliative care psychology. She also can do telehealth for the veterans that Jill and I work with. We have hematology and oncology psychologist, Dr. Kolva, that does when it comes to those diseases, individual counseling, and I believe she's still doing some group visits as well for veterans to have that camaraderie and support for the group. In my other clinic for geriatrics, we have a geropsychologist, and her emphasis is working with caregivers only to talk about dementia behaviors. How do you get the keys away from somebody that's been driving since they were 7 years old and will never give up? Or how do you work to get the firearms out of the house if it's no longer safe? So those are some of the things our geropsychologist does. A great resource is the Dementia Caregiver Survival Guide, and this was originally done by Dr. Natalie Edmonds. Here at the VA, we have adapted it to be veteran specific. So we know at end of life veterans have different types of PTSD than civilians based on their military experience. And so this is a great guide that is a workbook. Caregivers can go through it at their own pace. They can write in it. We really encourage this resource for folks that would benefit from it. Additionally, here at the VA, we have a peer-reviewed interdisciplinary team website for dementia resources for caregivers and their families. So over 100 resources, VA, non-VA, that talk about how to support folks with dementia as well as their families. We have advanced care planning group visits. So for folks that want to come in and complete, maybe bring their civilian spouse in to have them complete an advanced directive. That's why I highlight this, because sometimes it's scary to do it by yourself. What if you could bring your civilian spouse to the VA? You can both have an open conversation in a group to complete your power of attorney and walk out the door with this documentation completed. A lot of the things that I'm going to talk on the next slides are about the VA Geriatrics website. So I wanted to put that here because there are so many wonderful resources for our older veterans. And then many of you may be familiar with our caregiver support program, which requires a 1-hour presentation to itself. But this PowerPoint will go out afterwards. All these hyperlinks are good and active. And so this is a great resource for folks as we do the bird's eye overview. So this is where, Jill, I wonder if you can click on this geriatrics and extended care programs. I wanted to take a little bit of time here to talk about an additional 14 VA programs that are specific for older veterans. Ooh, you cannot do that, but that
Stephanie,
is okay.
can I ask a quick question?
Yeah.
This is Becky. As you're talking about all these benefits and the telehealth, and is it just for the veteran, or can a veteran spouse also benefit from some of these services, or are these services just veteran specific?
So most of these services are veteran specific. We like the advanced care planning, we allow spouses to come. In order for someone to receive healthcare doctor services from the VA, they need to be a veteran. With our caregiver support program, we acknowledge that in order for our veterans to thrive and be successful, their caregiver has to be well and thriving. And so that is a really muckety muck way to say VA healthcare is for veterans, and we support their caregivers, not with the same benefits for those that have served their country.
So a veteran that is the caregiver and serving a spouse wouldn't necessarily get the same home-based support that they would receive if they were the ones that were needing the care. Does that make sense?
Yes, but a veteran who is a caregiver for their civilian spouse, that veteran could be in the caregiver support program for education on how do they care for their loved one with dementia. Or they could get hooked up with brief session for primary care mental health team with a psychologist or a provider that can talk with that veteran about the stress around caregiving and things like that. So it's a fine line, but there are ways that we can support the caregiver.
Thank you.
And Jill, I'm gonna quick pull up that presentation, just because I think this is kind of a highlight for.
Yeah. Do you want me to stop sharing and you'll share quick?
Oh, that's a big question. Hold on one second.
Okay.
Um, there, here we go. If I can just send it to you.
Ooh.
We'll see what we can do from that perspective, and I'll talk a little bit on other things. In the meantime, I thought I was a whiz embedding things in a PowerPoint, and it turns out as an elder millennial, I am not. But I'm okay with that.
It is hard to show links from a PowerPoint. You are not alone. When they're linked and you're sharing your screen, it shuts down the PowerPoint. It's a glitch. It's not us. It's
okay. That's what I needed to hear today, Becky. I'm gonna come back to that. Not to dismiss it, but I'm gonna lose my train of thought. So I will loop back around to that, Jill. And I'll talk about the 14 programs. If we'll keep going, and I'll loop back around. So okay. I'm gonna break down some of those geriatric and extended care. Oop, can you go up one? Yep. Break down some of the 14 VA programs that are most commonly of interest to veterans and their families when it comes to VA benefits that we think of. With that information and the attachments that I sent to Becky, they're effective yesterday. They may be good for a month before something changes. And so the goal today is to give this information for veterans to say, hey, I might be interested in Vets Club or adult day programming. And then schedule an appointment with their PAC social worker to learn more. Do they have the functional criteria to apply for the program? Is there a copay? Every veteran's unique. So for me to say, here's 14 things you could get is spreading false information because it's based on the veteran, their ADL functions. Do they have dementia? Do they need 24/7 supervision? What kind of hands-on care do they need? So not to be nebulous, but that's the VA. And so we tailor things specifically to the veterans. The best way to get a hold of a veteran's primary care social worker is to call our main number, press 2, and leave a message with the call center to say, John Smith, I'm his social worker from X, Y, and Z. I have questions about this. Can you call me back? A lot of the times, veterans are eligible for these services. We need to know, are they dependent in how many ADLs, or what stages are dementia? Do they have memory issues where they're unsafe that they would then qualify for these programs? Next page, Jill. And then we think of community support resources. So the Elizabeth Dole Foundation has recently partnered with the VA for lots of caregiver support efforts. The Alzheimer's Association, other dementia-specific organizations, and we think of other disease-specific programs too, like the Parkinson's Association, ALS Association. We often refer to those. When it comes to rural veterans, this posting that I embedded in there may be a little bit old, but it is the Area Agency on Aging map for Colorado. And so as always, as a backup, if there's something the VA can't do, become familiar with your Area Agency on Aging. This is a colored map that has points of contact for every county in Colorado, and this is a wonderful resource. Veteran community partnership is kind of evolved a little bit here at the VA in the past few years, but Joining Community Forces is a great organization to advocate for veterans or seeking out resources. And we know veteran service officers are the experts when it comes to the VA benefits side of the house for home loans, aid and attendance, service-connected disabilities, all those money things do not come through the Veterans Health Administration, the doctor's office, where Jill and I and Laura Madeline work. They go through the Veterans Benefits Administration that deals with the money, the disability ratings, things along those lines. So at the VA as social workers, we cannot help veterans apply for their benefits. We can connect them to their local veteran service officer. We can provide a broad overview, but we can't physically take pen to paper anymore and help fill out that aid and attendance application.
Is it still true
So-
that if a veteran on hospice wants to get benefits, they go to you, or do they need to go to somebody else, or go to Laura Madeline, or?
Benefits is a tricky word in this situation. If they would like to access the VA's end of life benefit, that's where connecting with Laura Madeline or their PAC social worker to get connected is a part of the step. Home health care, things like benefits is a really big umbrella term. And so it's in lots of VA terms, but
Can I jump in?
Yes, please.
VBA, Veterans Benefits Administration, money, monthly checks. VHA, services, healthcare services. So when we talk about benefits, if we're talking about money and monthly checks, we're going to talk about the Veterans Benefits Administration. And if we're talking about healthcare and health-related services, we're talking about us, the VHA. Does that work?
Yes.
That's helpful. Thank you.
And so I'm going to dabble in some VA things here and still have time to loop back around. Just a little note, Tele Geriatrics is the other program that I work in, very similar to what Jill and I do in Tele Palliative, meeting with rural veterans. I'm going to define rural next, so then you'll have a better understanding of that. But I work with a geriatrician, a pharmacist. We're also age friendly. I'm a social worker. We do joint visits to assess for veterans, their function. How can we improve your life? How can we help the veteran caregiver improve their life with resource benefits? It is hard in rural areas because yes, the VA has home health care that can be ordered, but maybe if you live in Rocky Ford, there's not a CNA that can stop their job and sit with the veteran for 6 hours to provide that respite. And so it's a fine balance and a little bit extra legwork at time to coordinate services or what's available if the VA can't provide that benefit. I want to go to the next page, Jill. So when it comes to the dementia care, rural veterans, we would like the veterans to be 70 years or older or already have a diagnosis of dementia. And we do talk a little bit more about geriatric syndromes and helping with the management of behaviors. And we like to get rid of pills if folks want to deprescribe a lot of the same things that we talk about in palliative care, but we focus more on MOCA's the mentation piece, sometimes diagnosing dementia for those rural veterans that can't get into a geriatrician because there's not a lot of them here in our state. And we know that hearing and vision are very important. You have to be able to hear, you have to be able to see if you're going to get a test. And so the VA offers audiology, vision benefits as well too. So just covering the basics so that folks have the basic services that they need to hear, see, participate in life. So this is a map of Eastern Colorado healthcare system. If you look up top, it's notched out. That is the Cheyenne catchment area. So we have some veterans that live in Loveland and drive down to the VA in Aurora for specialty services. Sometimes they send veterans from the Cheyenne hospital down to the VA in Aurora because we're bigger. Jill and I, for the purposes of telepalliative care, will see any veteran in the state of Colorado, or we'll look at their chart and get them, if it's not us, we'll get them to the right team. Colorado Springs and Pueblo are highlighted because they are not rural areas. They are now urban. Jill and I like to see veterans from Kansas, Nebraska, the upper part of Colorado, and then pretty much from Pueblo down, from Colorado Springs west, and then starting in Bennett, Colorado to Kansas. So how do we define rurality? I take the veteran zip code and put it in a government Excel spreadsheet, and it pops out a number. Anybody that's 50% rural or higher is who we see. So places that I don't necessarily think of rural, but they are. Conifer has a high rurality. Falcon is not, but Calhan is. So if at any rate there's a question and a veteran needs palliative care, a consult to palliative care, everybody in palliative care reviews them, we get them to the right place. So if John Smith needs palliative care and veterans to go to New Mexico for their healthcare, it's really where does a veteran prefer to have their services. And then on the western slope is the Grand Junction VA that has its own hospital, nursing homes, is another section of Colorado. It's cut in half kind of with the mountains. How do we serve our rural veterans that are homebound or have trouble making it to the clinic? The VA has what's called a digital divide. So veterans that meet criteria that don't have internet service or a device to have video visits, the VA can loan them a tablet with built-in Wi-Fi for their VA healthcare appointments. It's pretty awesome. We send iPads. There's instructions that I included on the supplemental material to Becky earlier today. The VA has not magically found a way to get reception to places that do not have it otherwise. So we do run into veterans that live in valleys on top of mountains. A cell phone doesn't work at their house. The VA cannot get reception at their house magically. So that's in those cases, we'll have veterans that live in Rocky Ford drive to their local CBOC in Burlington or La Junta, because we know that not everywhere in the country has Wi-Fi or the ability to connect. The great thing with the digital divide is it also can come with peripherals. So if you're monitoring a veteran, there's a stethoscope, a BP cuff, a pulse ox, a weight scale, and a thermometer. The technology is getting crazy. This stuff is Bluetoothed. And so if Jill said, Mr. Smith, take your blood pressure, if those are Bluetooth to the device, in theory, on Jill's, on her appointment, we should pop up and see what the blood pressure reading is or what the pulse ox number is. So the VA is really at the forefront of technology, and that is exhibited by the digital divide with these ancillary services. My Healthy Vet. Have you ever heard a veteran say, I can't get a call back from my provider. I'm tired of waiting on hold. You know what a good option is? My Healthy Vet. It is the VA's online medical record system where veterans can access their own medical record as well as communicate with their healthcare team. I've put the link there and the point of contact. I recommend folks connect with My Healthy Vet so they don't have to go through release of information or wait for a call back. It is a great resource. Not well advertised. GeroFit, maybe not appropriate for veterans that are on hospice care, but it's a exercise physiologist who works with vets 65 years and older. They can come into the gym at CU Anschutz for in-person activities. They can do activities at their home on their VA tablet or their smartphone. So this is a great way for exercise without a PT or an OT walking through the door. From an agency, if we don't have an agency. The Annie Text Care program. I love working with folks that have dementia, so I highlighted the dementia protocol. But this is for caregivers of veterans, and they get 7 messages a week for a year that are educational or motivational, kind of checking in on their stress. Annie has apps for lots of different diseases or support, PTSD, depression. I highlighted the one for caregivers because this is a great resource, and you can start it or stop it at any time if it's annoying. But this is a way to connect, the VA to connect to our caregivers. Telehealth. We use a lot of telehealth and words here at the VA. A whole nother department is called home telehealth. And that's where the VA has daily monitoring of a veteran to help with their disease education, to empower them to learn their own chronic condition management at home. There's a list of disease management programs that are available, from medical related to mental health. Some veterans graduate, some roll right back in, and or you can enroll and unenroll as you need to. If 12 months isn't enough, we'll get you back in there, especially when it comes to managing medications and pharmacy needs. This is a pretty great program where a nurse will call the veteran, check on, if their weight is up a lot. Oh, Mr. Smith, I noticed today you're up 3 pounds. Let's talk about your fluid for your heart failure, things like that. So it's pretty cool, I think, and a different form of telehealth through the VA. There is an app for that. That is my new VA motto. On this VA mobile website, there are apps for veterans, for caregivers, connect to your doctor, PTSD. I think there's like 7 pages of apps. We're really moving forward and getting with the time for all those young youth that like to do things on their smartphones. In addition to that, the VA has the 24/7 help desk for veterans when it comes to if they do a video visit, if they're having challenges. This does not go to the hospital, so it goes to a techie place of people that the VA pays to help veterans and their family members triage issues with iPads or other VA technology. This program I thought might not always be appropriate, but it's worth sharing that the VA from COVID started a telephone lifestyle coaching program. This isn't meant for people that are alcoholics or have challenging medical conditions. This is more for people that maybe had a couple extra drinks during the pandemic and wanted to work on decreasing their consumption, or want to take off a couple extra pounds from the pandemic. You get 10 calls from a coach that is a certified healthcare practitioner. They have this crazy schedule where they will find you even if you work, 3rd shift, and they can help with stress, eating, some different health factors. This is a great program that's not fully in effect, but I wanted to just share about the Compassionate Contact Corps. Great idea of connecting either virtually or by the phone for folks that are lonely, homebound, just need a check-in. This isn't a substitute for the Veterans Crisis Line for someone that's having suicidal ideation, but more of a remedy for loneliness and a connection, where here at the VA, our volunteer services, a non-clinical person is a social prescription for connection about once a week, just to check in and see how things are going. Ooh, okay. Now I'm going to use this time and I'm going to pull up that other PowerPoint because I have the time. Is there any questions in the meantime while I'm multitasking for either Jill or I or Laura Madeline? No questions.
Stop sharing.
Can I just forward this to you, Jill, and you'll share it?
Yeah.
Based on my on-the-go status for today.
I think we're overwhelmed by the volume of opportunity. I mean, it's just amazing. And since we do home health and we have, I think we're sort of semi-rural with Conifer Bailey, Central City, Georgetown, we can in and out of your area. I think this is just an amazing exposure for me.
And I'll share briefly that Jill and I are working on a pilot project through our geriatric research program. That's just starting 6 days ago, and we've done absolutely nothing. But we have our vision is that Jill and I will do a hybrid palliative care home visit for rural veterans. We know there's veterans that live in Fort Morgan or Linden, Colorado, that they don't have any hospice or palliative care options. So if you have veterans that can't get access or services otherwise, but they would benefit from palliative care, hospice care, Jill and I want to know about those veterans, and we want to work towards enrolling them in our pilot program where we have a hybrid palliative care occasional home visit, because we know they're rural. It's going to take us a while to get there, but using the tablets and having, 2 team members, a nurse practitioner and a social worker, then we are able to really efforts to support our rural veterans. We know they want to stay at home. They don't want to go anywhere besides their home. And so we have that project coming up, which I'm really excited about. So, Wendy, you were overwhelmed. Careful, here comes the fire hose.
I was just
Jill,
gonna say,
go.
You can see this okay, yes?
Yeah, we're doing good.
Jill's voice is a little quiet. It's hard to
Oh
hear.
yeah, she didn't.
Okay.
She likes to talk with her headset
Oh
up.
yeah, I always forget. I'm sorry.
That's
That's
okay.
okay.
So I think I put this is another PowerPoint I gave at our Healthy Aging Fair 2 weeks ago, I think. So I figured this would be great to interject here. Jill, are you able to go to the next slide? Maybe. Anticipation is killing me.
How far in do you want me to go?
Go to page 2, I think.
Oh, okay. Sorry, I went way far.
In my screen, it's not moving.
Oh. Is it moving for other people?
No, I don't think so.
No.
I wonder.
No, it's not moving.
Oh, it's moving for me.
Yeah,
Well,
we're still
that's
on
not
page
fun.
1.
Do you have a
Oh,
couple
'cause-
screens? It might be that you're sharing a different screen.
Yeah.
Oh, let's try this one. Is it moving now?
No, but you zoomed in
Okay.
a lot.
Yep. Hold on.
Oh, it's moving.
Oh,
Something
it was
moved.
moving.
But it's teeny tiny, right?
Oh, it's kind of big and kind of not all there.
What? Hold on. I have a plan.
I'm thankful you two are human because I do so many Zoom presentations and still things always happen. It just,
Oh yeah.
so I imagine maybe you can speak to that. Technology is a great asset, but also for our older veterans who are unfamiliar with it, how challenging it might be. How you said you have a helpline or like a IT support for everyone that receives.
Yes. For whether the veteran has a VA loan tablet or they are using their personal device, the Office of Connected Care is a national program that has a 24/7 help desk, and it can help veterans or their family members with connectivity. There's 2 handouts on how to work a VA loan tablet that are in the email that will go out later. So
Did it work? Am I on page
yes.
2?
Yes.
Okay.
So
Woohoo.
here are 14 VA home health VA programs that I'm going to give a bird's eye view of. Veterans that want to know their specific benefits and eligibility should connect with their PAC social worker. So home-based primary care, I briefly touched on it. I think what's important on this slide is what areas does it cover? Denver Metro, 35-mile driving distance from the VA in Aurora. They don't go past E470 for the eastern boundary. Southern Colorado, it's a pretty big area, but it covers Canyon City, which actually is highly rural. It doesn't go to Woodland Park, which is rural, but it goes up to Cascade for those southern folks and all the way down to Colorado City. The next program is medical foster home. So as an alternative to nursing home placement, veterans can live in a civilian, a caregiver's home with their family. They have their own room. This is a great way for veterans to avoid institutionalization in either an assisted living or in a nursing home and live with their caregiver that provides 24/7 care, as well as having that support from home-based primary care for veterans. And this program is available in the Denver metro area only right now, and the same radius of home-based primary care. Veteran-directed care. I will be very brief on this because we had a presentation, but really veteran-directed care for our rural veterans that have someone providing care for them. This is a great solution as long as they have those ADL dependency needs, hands-on care consistently. Look at all those counties that are covered, and this is just in Eastern Colorado. So if there's a veteran on the Western Slope, they have their own program, but within the Eastern Colorado healthcare system, take a look at all those counties where we have the veteran-directed care program available, which is CDOS with no income criteria. I've learned to start saying that. So when we think of Vets Club or adult day healthcare, this is a VA benefit where we encourage veterans to go for socialization. These programs are community-based. The VA contracts with them, so there are civilians as well as veterans that attend. I found that usually the veterans have their own little cohort within these programs where they can go and have veterans coffee, or they do some special veteran programming for veterans, so they like to go on those days. As for rurality, we have a place in Frisco and a place in Salida. So those are our furthest away ones, with most of them being in the Denver metro or Colorado Springs area. PACE, Program of All-Inclusive Care for the Elderly. For veterans that qualify for nursing home level of care, being 70% service connected or higher, the VA will pay for their enrollment into the PACE program in lieu of nursing home placement, because the goal is to keep folks in their home versus institutionalization. So we currently have contract with the InnovAge program in the Denver metro area and in Pueblo, and working on a contract with the Colorado Springs PACE location. Veterans can also use Medicaid and enroll in PACE, and we have the PACE social worker has some oversight for veterans, mostly for the ones in the VA, but also oversight for those Medicaid veterans because they still are veterans. Jerry PACT. We talk a lot about PACT. It's Patient Aligned Care Team. That is your primary care provider at the VA. Sometimes veterans would like to have a geriatric focused care team. And so we have in the Rocky Mountain Regional VA Medical Center for all veterans in the Denver metro area, they can have geriatric specialty providers for their primary care. There's a wait list currently, but we have a great group of geriatricians. We talked about palliative care. Jill and Laura Madeline are representing today for our inpatient team, or our outpatient team at RMR. Again, we talked about the rural programs. These are my two real jobs here at the VA. Dementia care team for folks in the Denver metro area that would like to get connected with a geropsychologist, a social worker, and a Jerry psychiatrist. We have lots of Jerry specialty folks. This is a team that does episodes of care for helping with education, doing a roadmap for dementia, future planning, connecting into services. This is really a great resource as well for those veterans in the Denver metro area. Community nursing home program. I think this is key. I attached the current list to the email that went out. Here's the criteria for veterans if they're eligible for the CNH program. 15 locations in Denver metro, 8 in Southern Colorado. If a veteran's eligible based on this criteria, they can go for skilled rehab, long-term care, respite, and then every veteran is eligible for the end-of-life benefit. Again, is there a copay or questions on eligibility? That's where contacting your social worker comes into play. Did you know the VA has its own nursing home? It is in Pueblo, Colorado. It is our Pueblo Community Living Center. There are 25 male long-term care beds available, and across the country, the VA has over 100 CLCs that only accept our veterans for care.
I have a question, Stephanie.
Yeah.
Do they take active duty service members?
No.
No, just veterans.
Mm-hmm. Laura Madeline, do you know differently if I'm fibbing?
I've never been asked that. I don't know the answer.
Okay, thanks. I think that for active duty, the VA has the CCN. We have Laura Madeline, I may beckon to you. What's the CCN stand for? Oh, good. We're both stumped.
Community Care Network.
Yes. There are a couple additional nursing homes that are not on the CNH list that veterans may be eligible for. That would be a specific question for the
But
PAC social worker.
not for the end of life benefit. So for this
Correct.
group, I wouldn't get too
Yep.
much into that. It's only going to be for rehab.
Yep. Sorry, squishy questions for the government. Here's a quick blurb on hospice and concurrent care. We had brochures created this year. Those we have a separate palliative care, hospice and concurrent care. Those will come out in email. Those are eligible for veterans and their family members. Great written documentation on what we can do to support veterans and hospice agencies. Respite. We love respite. The VA has two types of respite. One is an in-home visit for 6 hours, where the VA will pay for a home health agency to send in a CNA for 6 hours. Every veteran gets 30 days per calendar year. It's use or lose. They don't roll over. It's in the best interest that the veteran and family count their respite days and plan them out. If you start on January 1, you can do every other week, which is 26 times and 4 days to use PRN. The flip side to that is nursing home respite care, where veterans can also go 1 day equals 24 hours. Usually these stays are 5 to 7 days at minimum, so that the caregiver gets a break if they have to travel to a wedding out of state or have surgery, things like that. VA respite could have a copay, it could not. So connect with your PAC social worker for individual criteria. Homemaker home health aid. Here at the VA, we do a lot of homemaker home health aid. Services for our veterans, they do need to have ADL dependencies in order to qualify for this benefit. If you need a CNA, the VA will then order a homemaker home health aid to go along with that. Homemaker services cannot exceed 40% of the time that the caregiver's in the home, so that a majority of it is CNA with some support with light homemaking for changing the sheets, doing the laundry, light meal prep, things that are in that area that are in the veterans area, the veterans bathroom, not the spouse's bathroom. It's not a whole house cleaning service. It's specific to the veteran and where they reside within the home, if it's separate quarters. Boom, I did it. 14 VA programs. Everybody call your social worker to see what personalized things we talked about today each and every veteran is eligible for. Yeah, 4 minutes for questions, if your mind is not blown.
Thank you so much for all of that information. It is good to know we have handouts and access to the PowerPoint. Thank you for that. Any questions?
I still am amazed. There are three of you on here from the VA, and you oversee all of this. Just blows my mind. I mean, you are just absolutely the most incredibly dedicated overwork group I've ever run into.
Thanks, Wendy. Appreciate
And
that.
I thank you, and I really thank you for what you do for veterans. It's just extraordinary, extraordinary.
I think we're all here because we're passionate about the folks we serve, and so you know, the VA does a lot of great things, but we don't have hospice. So that's why I appreciate this group, is that you can continue the mission of the VA to serve those who served.
It's really encouraging to hear how much you have for veterans. There's a lot more than I think many people know. Even a couple of my veteran volunteers, talking with them, I learned they aren't enrolled in the VA to get benefits. And yeah, to learn, I heard something, and I'm trying to remember, like there's some coverage even for some integrated health through the VA, like acupuncture and craniosacral and things that a lot of times aren't covered with other insurances, are covered through the VHA. Is that what I should say?
Yep. We're the Veterans Health Administration.
Look, Laura Madeline, I'm teachable.
You're doing great. And I just want to, you talked about enrollment. That's the first step. Let's try. I'm trying so hard to be proactive, and I really appreciate our hospice partners and hospice social workers. Let's get veterans enrolled before it's an emergency. We have a lot of enrollment issues. So, you know, let's be out there and be that public voice. Get enrolled, whether you need it now or not. Get enrolled. Be in the system. It will only benefit you in case you do need services, especially end of life services, because those are timely, and we can get stuck in some paperwork enrollment back and forth that's difficult for veterans and their families and our community partners. So I really appreciate the proactive push for enrollment.
And I just want to say, as a veteran, I appreciate all of the services that you do for our fellow veterans. And I am really happy that the call times are a lot less than they used to be, I feel like.
Good.
Thank you, Tyler, for being here.
Absolutely.
Next is Dennis on the line. I know that he had some problems hearing. Are you here, Dennis?
I sure am, and I can hear you fine.
Oh, good. Can you give just a quick what we have coming up for next month?
Yes. Mr. Salazar from the Wounded Warrior Project. He's a regional director for alumni, and he will be giving a brief presentation on the Wounded Warriors, and will be joined by a veteran who is part of a program that's part of Wounded Warriors called Warrior Speaks, to just share a little bit about his own story with us. So it's going to be exciting. They're really looking forward to getting to know our group. It was fairly new to them, so it was good to be able to give an introduction about, you know, how much we care about the veteran communities that we serve, and how we'd like to work with ancillary groups such as his. So yeah, look forward to seeing you all next. I guess the 3rd, is it? Is it the 3rd of November?
Whatever the first Friday is.
Right. Friday, November 3rd, otherwise known as the day before my birthday. Just
oh, okay. Good to know. Well, thanks for
Yes.
setting that up, Dennis, and thank everybody for their time. Stephanie, your email to me said you're off today, but you're actually here on this call. So that is a gift to us. Thank you so much. Have a good day.
Thank you for having us. Bye-bye.
Bye, everybody.